to this. Okay. Now I'm going to share my screen again. And we will start. So if anybody hasn't pressed mute, if they can please press mute on their own computer, and away we go. So we're talking about back pain today, in particular sort of chronic back pain. So the target, there's just a number of slides that I'm going to go through. And so I'll just run through those slides. And as I say, if you've got any questions, just click on the chat button and just write a chat question. Otherwise, we'll take any other questions at the end. So if I can just talk about chronic lower back pain, this is the sort of, hopefully, the target audience that we're trying to talk to. So first of all, if you're somebody that has persistent or recurrent non-specific low back pain that has lasted for greater than 3 months. So the key point there is the time. So it's got to be a long-term back problem, greater than 3 months, not pregnant, over the 18 years of age, and that you don't have a serious medical history related to your back pain. So it's got to be a fracture, a spinal tumor, major psychological problems, something like that. People that are sort of ruled out of what we're talking about. And then the last one is, hopefully you've tried other options like exercise programs or medications that haven't been successful. So that's the sort of target audience. But if you're not one of those people, it's still hopefully an interesting presentation. But they're the sort of specific people that we're interested in with this presentation. Okay, so just a bit of background on the whole back pain debate. So, back pain is a leading cause of disability worldwide, and that burden is unfortunately increasing. In Australia, back pain is the #1 cause of lost productivity at work, early retirement, and income poverty. This is out of the Medical Journal of Australia. So it just shows that back pain costs the health system about $5 billion annually. And it's the most common health reason forcing middle-aged Australians to retire early. And it reduces Australia's gross domestic product by more than $10.5 billion annually. So I guess the point there is it's a big problem. It's in Australia, it's the second most common reason that people go to their GP, and it's one of the top 5 reasons that people present to ED. So it's a big health problem. But the risk of recurrence and progression after an episode of back pain, this is an interesting one, that about 75% of people that have an episode of back pain will recover, or will have a favourable outcome with or without treatment. So, that's a good statistic if you're a physio, but about 75% of people, your back pain will recover, but about 25% of those people will develop ongoing symptoms and limitations. And it's those 25%, I guess, that we're kind of trying to target to get a better result with. Just a couple more slides just to give you a bit of a scope of the problem. So here's a graph looking at the prevalence of back pain with age. And I guess the point of this slide is that, as you can see, that basically every age group from age 10 to 90, back pain is prevalent. So if you're under 10, there's very little back pain. Once you hit 10, the numbers are pretty consistent amongst the age groups. Obviously around that 30, 40, 50, 60s, the numbers go up a bit. And women are slightly more prevalent than men, but it's a problem that affects every age group. It's not just a young person problem or an old person problem or a working age person's problem. it affects everybody across the age group. And I think the last slide that just to give you a sort of a background to the problem is a bit of a disappointing one. This is to do with the global burden of back pain with age. And again, it shows that across the age groups, it's a problem. But, the big issue is that the red graph is 1990 and the blue graph is in 2015. So what we're seeing is that back pain is becoming a bigger problem across every age group in that 25-year period. So, despite all the advances in medicine and health, back pain is becoming a bigger problem, not a smaller problem. So we're not winning the battle with back pain, I guess, is the key. All right. So one important point here is one change in thinking in the last 5 to 10 years is that the causes of back pain are not what we traditionally have thought. So in the past there was a lot of emphasis on obviously poor sitting posture, on how much time you spend lifting, how much time you bend forwards, trauma, degeneration of the spine. Those were the things that people were looking at as reasons why you would develop chronic back pain. And unfortunately, all of those things have been shown not to be causes of back pain. So the more recent evidence and research in terms of the cause of back pain are some of these factors. And just to go through a few of them briefly, I guess the thing that the key point is some of them are what they call modifiable factors and some of them are non-modifiable factors. So genetic factors, unfortunately are a predisposer to back pain. And so that's obviously a non-modifiable factor. But things like comorbidities, which is other conditions that you might have, like asthma, diabetes, poor nutrition, obesity, they are some of the very strong causes of back pain. And so, they're definitely modifiable factors. Social factors are very important. So, unfortunately, education level, low income, poor access to health care are key factors in the development of back pain. And so, again, they potentially can be modifiable factors. Psychological factors are very important. So, depression, anxiety, low self-efficacy, which is not looking after yourself, or low self-esteem are big factors. And the biophysical factors, which is basically to do with how your body is dealing with the pain, which again are modifiable factors. So these are the things that have been shown to be more strongly linked to the development of chronic back pain than some of the things that we thought about earlier. So again, this is another slide just highlighting some of the key factors that cause people to go from an acute episode of back pain into a chronic episode. So unfortunately, it's things like beliefs that pain and activity are harmful, low or negative moods, mental health comorbidities, treatment that does not fit with best practice but remains the focus of patients' requests. It's those sort of issues that are the key, more so than posture, heavy lifting, those sort of things that we thought of in the past. So, basically the paradigm or the thinking about back pain is changing based on the research. So again, the first line of management for back pain should be things like advice to remain active and stay at work, patient education, exercise therapy. The common recommendations should be things like anti-inflammatories, cognitive therapy, could include some manipulation or acupuncture. And the sort of things that are being more recommended against are things like opioids, injections, and surgery. And I just wonder, everybody's that's here, what your experience is like, where those recommendations have fitted into your experience. So again, if you've got a comment, just put it in the chat section. So the Australian Commission on Safety and Quality in Healthcare is one of the sort of key drivers of clinical standards in Australia, and they're the ones that do a lot of research. And so in 2022, they came out with their clinical care standards for low back pain, and they always come out with this quality statements. And so, as you can see in the highlighted, the key things are patient education and advice, encouragement of self-management and physical activity, and physical and psychological interventions. They're the key treatments. And number 3 is an interesting one, which is less imaging. And number 7 is an interesting one, which is less use of pain medications. So those are the guidelines, and again, I just wonder how closely they're being followed in your experience. Just to talk briefly on the aspect of imaging, and so this came out of that same standard, the Australian Commission on Safety and Quality in Healthcare. And so this is the prevalence of findings on scans in asymptomatic patients with back pain. So to highlight a couple of things. So say disc degeneration, if you're say 50 years old, 80% of scans will show that there is some disc degeneration, whether you're symptomatic or not symptomatic for back pain. So whether you've got pain or not, 80% of scans are going to show disc degeneration. 60% will show a disc bulge. 32% will show facet degeneration. And so I guess the point there is, how useful is having scans to help manage your back pain? I mean, in my experience as a physio, every patient that comes in has got a big pile of scans with them. And the question is whether they're helpful or not in terms of managing their problem. This is another quite heavy slide, but I guess the point there is, in terms of decision flow for imaging, the only reason why people should, really need imaging is if they have cancer, severe neurological defect, or a spinal infection or cauda equina syndrome, which is basically your spinal cord is being cut off, and so it's causing fecal and urine problems. So, the message there is that there's too many people having scans that aren't necessarily helping with the management of their back pain. All right, so let's just move on to onto management. And so one of the key things that we wanted to talk about today is this idea of CFT, or cognitive functional therapy. And so this was the big study that came out a couple of years ago, 2023. And they looked at 3 groups of people. One group had usual care, which is whatever you normally would do for your back pain. One group had the CFT intervention, and one group had CFT and biofeedback, which is where they sort of stuck probes onto your back and they looked at, how your back was moving during the CFT. And basically the usual care group stayed the same, but the CFT and biofeedback groups improved. And the key part of this,
Turn that light off.
the key part of that study was that the intervention was only 6 to 8 weeks of treatment, and that's it. But the benefits of the treatment were still the same at 12 months, and so that's the thing that I think got everybody interested is not just that a particular intervention had some effect, but the effects were maintained for 12 months despite no more actual treatment. So I guess the question is, what is CFT? What did they actually do, to make this sort of longer term difference? This is the CFT slide on what they actually did, but I'll try and sort of just break it down briefly. So this is probably the most important slide of the evening. So basically between CFT and glad back. So CFT is basically, or cognitive functional therapy is a one-to-one session, and glad back is a group program. So they're both exactly the same, but CFT is something that you do on just with a one-to-one session, and glad back you can do as a group program. And basically CFT is CBT and exercise. So it's cognitive behavioral therapy plus exercise. So there's three sort of key components to it. The first thing is making sense of your pain. And so you need to spend a fair bit of time with people sort of working through their thoughts, beliefs, feelings, and fears. And the idea there is that, what you think affects how you feel, what you do affects how you think, what you feel affects how you act. And so you need to actually unravel what is behind the way people are moving and the way people are experiencing their back pain before you actually try and do anything about it. So that's the CBT part of it. The exposure with control part of it is the second part, which is basically actually getting people to move and build confidence to re-engage in activities. And again, there's a process there, which is kind of beyond the time that we have. But I guess the example is, if somebody has a problem with bending forwards, so you need to actually go and try and work with them on why they have a problem bending forward. So the background of it may be that they've been told that they shouldn't bend forward because that's going to put pressure on their spine. They may have had an experience of bending forward that's caused back pain. And you need to actually sit down and work through that with them before you actually get them to do that movement. And so I guess people are going to be thinking, this is like a bit of a combination of psychology and physiotherapy, and it's true. But, I guess the physio would usually want to come in and just get people starting to do exercises and movement and give you a list of exercises to do. And you may have all these reasons why you don't want to do it or can't do it. And so that's ineffective. Whereas the psychologist might sit you down and work through all your fears and beliefs and thoughts about why you shouldn't move and come up with a plan there. But unless you actually then go and do those movements, you're not going to be making progress. So you need the CBT and the exercise together. And then the third part is the lifestyle changes that you actually have to go out and take those understandings and take those exercises into actually your lifestyle. And if you don't actually then make the transition into your lifestyle, then anything you do in the clinic is a waste of time. So that's a very sort of concise way of trying to explain CFT. So if we just talk briefly about glad back, this is kind of a diagram of how the glad back program works. So the first part of it is at the top is an assessment where you go through 4 tests. You go through what goals you have, and you have to work out your goals very carefully. Like if somebody says, I've had 20 years of back pain, I want to run a marathon next year, that might be not a very smart goal. Then there's 2 group education sessions where you go through some of those thoughts, beliefs, understanding about back pain. Then there's a group exercise session. There's 2 sessions per week for 8 weeks. And then there's a reassessment in week 10 where you basically go through those tests again and the SMART goal. So the education session is really based on trying to understand these 8 statements. And so again, I wonder what people think about these statements. So for example, the back is strong, the back is made for movement, the brain can turn up and down pain. So basically we need to work through these ideas and see what people think about before you actually get onto the process of actually doing the exercises. And so there is, in glad back, there is a series of exercises. There's kind of 9 stations that you go through, but it's not really, a progression of going from easier to hard. It's not really saying you need to do 3 sets of 10. It's basically helping people, work through what works for them. So it's a bit less prescriptive. It's a bit less rigid. So here's again some of the other ideas that we go through that you need to sort of think about and embrace, when before you actually get into back pain. So if I just mention a few of them, so lower back is rarely a serious medical condition. I mean that doesn't mean that it's not a seriously painful condition or a seriously concerning condition, but it's rarely a serious medical condition. So ideally we should be able to get to the point where less people are going to emergency for back pain. So most episodes of back pain get better. Lower back rarely means that the spine is damaged. Scans are not needed for most people with lower back pain. Avoidance and overprotecting the back delays recovery. Pain flares are not usually a sign of tissue damage. Again, I wonder what some people think of that. Here's an interesting one. Posture does not predict pain, and a weak core does not cause pain. So again, this is quite a big change in understanding in back pain in recent years. It's not necessary, it's not saying that strengthening your core isn't important, but having a weak core is not necessarily the cause of your pain, and posture does not predict pain. Strong drugs and surgery are not usually needed. All right, so just the last thing I want to talk about is other interventions. So again, these are some common things that people do and have looked at. So medications, injections, radio frequency lumbar facet joint denervation, where they block the nerve supply to the facet joints, spinal cord stimulation, and surgery. And I'll just quickly go through some of the research around that. So this is New England Journal of Medicine, showing that pregabalin, which is Lyrica, is not effective in helping people with sciatica. But again, Lyrica is a very commonly prescribed medication for sciatica. This is the Cochrane Library, which is really the gold standard for medical research, where they basically do what's called systematic review. So they go through and look at all the research on one area and put it all together into a statement. So steroid injections appear to be slightly effective at improving short-term pain and function in people with radicular low back pain, not due to spinal stenosis. Cortisone injections is probably ineffective for spinal stenosis, but yeah, maybe slightly effective in people with low back pain. Radio frequency denervation. So this is again from the Cochrane Library. It was 2015, so hopefully there's been some more research in the last 10 years, but the authors found no high quality evidence suggesting that radio frequency denervation provides relief with chronic low back pain. High quality controlled trials with larger patient samples are needed. Spinal cord stimulators. So again, I'm not sure what people have an understanding of spinal cord stimulations, but this was 2023. Data in this review do not support the use of spinal cord stimulators to manage low back pain. Current evidence suggests spinal cord stimulators does not have sustained clinical benefits that would outweigh the costs and risks of surgical intervention. And then again from the Cochrane Library, surgical versus non-surgical treatment for lumbar canal stenosis, which is, a particular type of back problem where there's narrowing of the spinal canal. So there was 12,966 citations screened, 26 full text articles, and 5 random controlled trials showing we have very little confidence to conclude whether surgical treatment or a conservative approach is better for lumbar spinal stenosis. And we can provide no new recommenders for clinical practice. However, it should be noted that the rate of side effects ranges from 10 to 24% in surgical cases with no side effects reported for any conservative treatment. That's spinal surgery. And then this is the Medical Journal of Australia saying that spinal surgery has a role in alleviating radicular pain from neural compression or where back pain relates to cancer, infection, or gross debility. Spinal surgery for all other forms of back pain is unsupported by clinical data. I guess my point is all of these other interventions are options. And, I'm not saying that people shouldn't do them or shouldn't have them, but I think there's a lot of work that people should be doing before they embark on those interventions in the exercise, CBT, CFT, glad back space, and then these should be offered as last resorts. And again, from the clinical care standards, if you just look at the shape of the triangle, you can see that at the starting point, there should be advice for education and self-management. Then the next step is to go into one of these types of programs that I was talking about, and then the last resort is is some of those other interventions. And unfortunately, I feel like sometimes the triangle's upside down, and people are coming in to see me, and they've had the scans, they've had the injections, they've had the surgery, they've had the all of these treatments, and it's like the actual exercise intervention is the last resort. And it's like this should have been the other way around. It should have started here and then progressed to there. And so it's almost like, well, where do I even start in this situation? They've had there's too much that's already gone on. All right. That is all I wanted to present. So thank you for listening to all that. So I'll just Have I stopped sharing my screen?
Yeah.
So we're back on the Zoom, and I'll just actually have a look at the some of the questions that we've got through. And so again, if there's any more questions, I'll I can only see one at the moment. So if there's any other questions, you just pop them in. Otherwise, I'll just have a look at this one. And thank you for the person who's talking about bending forwards and straightening up. And you make a very good point that bending forward is not in my imagination. And I guess that's a very key point, is that nobody is saying that bending forwards is not painful for you. And it's not in your imagination, but there's a lot to work through as to think about why it's painful and what's behind that being painful first, and then trying to find ways of working out how to help you to bend and straighten up in a way that's not painful, and then actually adding load onto that, and then you'll be able to take it into normal activities. So it's very important to understand that hopefully no one's saying that it's in your imagination and the pain is not real and it's all in your mind, and how you do it. But there are going to be issues behind why it's painful when you bend that we can work on. So this was my concern in giving this presentation, because a lot of the the ideas and the answers are going to be very simplistic, but I'm happy to chat to you about that another time off camera, if you want to sort of talk through it in more detail. So let's see. All right, very good. So that looks like that's the only question on the chat. So I'm just wondering whether there's, oh, maybe there's one more. What does that say? My pain is sporadic. I can do aerobic and resistance exercise without any low back pain. That sounds good. Again, probably a good, I'm not sure how to answer that, but probably a good time to do the exercises is when your pain is less, and do more then and less when your back is sore. I guess that's the only thing I can say to that. I'm just wondering, so if there's any other questions that people want to ask. I guess the idea of the presentation was hopefully to provoke some questions, as much as providing information. If you've got a question and you might have muted yourself, you need to unmute yourself before you ask the question. Can you give some exercises that are generally helpful? Yes, I can. unfortunately, what's going to be helpful for one person is not necessarily what's going to be helpful for the next person. So again, that that might be one that I'm better to sort of talk to you one-to-one about that. But yes, there are exercises that are generally helpful for most people. I'm not, again, I've the idea would of the presentation was more just to give some information about CFT, as a concept, which is a fairly new and emerging idea for how to treat back pain. But I can definitely give you some exercises. I can send you some exercises that will be generally helpful. Spinal fusion, study pantosis immediately. Milo, tight, overall happy. I've started playing golf again, still scoring badly. Ha ha ha. Very good. Yeah, and so I guess it's important to say that I'm not trying to say that those other interventions are not legitimate options. I'm not trying to say that, but I would hope, and I think I know who that is. That if you've tried everything else and really had a good go at the non-operative treatment, then absolutely that's the place to be. So I'm not trying to say that surgery is not an option, but I feel like there's an overemphasis on people going too quickly for those other interventions that are costly and not necessarily the gold standard as first line treatments. So I'm just trying to even out the landscape. But yeah, if you've done all those things and really had a red hot go of exercise and the things we were talking about, then absolutely surgery is the option. Yes, we are CFT trained physios. So one of the physios, Hu Chang, is currently part of a trial that Macquarie University is running, which is basically that restore trial that I showed you. The next phase of that is looking at how to implement it into private practices. So he's doing the training for that research project at the moment. And as I say, the GLAD back program is based on the same research and understanding, but it's in a group setting. Very good. Any more questions there? Thank you for everybody for asking the difficult questions. All right. Looks like everybody's happy.
In Australia, billions of dollars move through our economy from property settlements and business.
I'm not sure who who that was. Here's another question that's come through. How responsive of are doctors to this approach? Yeah, I'd say probably a mixed response. I think some of these idea, you know, some of this new research is fairly new, and so it's pretty much coming on pretty slowly into the, you know, everybody's radar. It seems to take 10 or 15 years before research translate into clinical practice. But, you know, I think it's like the GLAD program that we run for hip and knee problems. I think you know, the understanding and the take up is growing, and I think GLAD back is a bit behind that. But, you know, I would say that it is a bit of a frustration that you know, a lot of these guidelines are you know, are being brought out by you know, the health industry and the medical profession, but sometimes not that well followed. So there probably does need to be some education around that. Still needs to happen, but yeah, it does take time.
Space heater is being called the Tesla of heaters. It can warm up a freezing cold room from 7 degrees to 20 degrees in minutes with...
Somebody's multitasking at the same time. Is it better to keep exercises with taking anti-inflammatories or painkillers, or when I have some discomfort, or is it best to stop exercises until pain reduces? That's a good question. Yeah, I think it's you know, both, I would say. I think it's definitely good to keep moving, but it's also not good to move in a way that aggravates your pain. So there's definitely, you can do too little movement and you can do too much movement. So it's about trying to find the balance somewhere in between. So I would definitely warn against pushing too hard and just aggravating your pain. But at the same time, if you've got chronic back pain, rest is not going to help you. So yeah, I guess
Need to move.
There we go. That's a good answer. Thank you. Yes, I will. I can get there can be a copy of the slides, and I've also recorded it, so it'll be available on our website if you want to have a look at it. But definitely, if you feel free, if you want to call the practice, I can email you the slides. Ooh. One of your physios is using same approach of letting him treat the shoulder problems than procedures. Not sure. About that one, but that sounds good. All right, any last questions before we call it a day? There you go. That's a nice comment. Said the surgery was warranted. The pain was very bad at the time. The pain resolved overnight. Glad I stuck with the physio exercises in time. And yeah, I think that's, you know, that's good. As I say, I'm not trying to be overly negative about those other interventions. I'm just saying that people need to really push the non-surgical treatment first before they consider surgery. And I guess spinal fusion is is a good example where spinal fusion can be very helpful in helping pain, but you know, at that level, it's only 10 or 15 years before it's going to start causing problems at levels above or below. So, you know, you've got to think carefully about it, you know, whether you've really explored all the options before you jump into it. And if you have, you've done everything and you're still struggling, then absolutely that's for you. So, you know, I'm not trying to say there's, you know, there's no role. It just should be last resort. All right, very good. I think we're done. Thank you very much, everybody. I hope it was helpful, and please email or call up if you have any questions, or very happy to send out those slides. I appreciate everybody's time. Thank you very much.